Hello, we'll just give it another couple of minutes to see if anybody else joins, and then we'll start the talk. Hi guys, sorry about that. Welcome to the talk today. My name is Holly Mould. I'm an F2 working at Aintree Hospital, and I'm part of Thursday 15 teaching group. Thursday 15 are a group that have run a regular revision series for finals. We did a PSA preparation series, and this is an event I'm running as an SFP doctor to prepare you for your SFP interviews. I'm an F2 doing an education SFP. I'm currently on A&E, but my education block is coming up in December. There's not many of us here tonight, so I want to keep it nice and interactive. So if you do have any questions, please just raise your hands. And that reminds me, I just need to activate the chat, I believe. So give me 1 second. Great. So I think you should now be able to post in the chat and in the Q&A. And just either unmute yourself, raise your hand, or put something in the chat if you want to ask anything. So this is the second in our SFP application preparation series. And today we're going to cover sort of common interview components, an A to E. So that's your clinical station, the critical analysis station, the portfolio station, and then we'll do some practice questions at the end. And then if you have any questions yourselves you want to ask, fire away. Okay. So the first session we covered white space questions, what is the SFP, and the general application process. So just a poll for you now, just to see where everybody's at. Have you applied to the SFP and you're sort of waiting to hear, or are you okay, so great. Most people have already applied to the SFP and we're just waiting to see Okay, perfect. And just put in the chat, have you guys mainly applied to the Northwest, or are there other places that you've applied to? Northwest, West Mids, Northwest. Okay, perfect. So Sam, I'm going to be honest, I applied to London and Northwest, so I'm not 100% confident with what the West Midlands ask for in their application and interview process, but I'm hoping a lot of the stuff in this talk will still be applicable. It's certainly applicable to the Northwest and the London interviews that I attended. So hopefully it covers quite a broad range of topics. So we're now at session 2, and interviews and decision making for the deaneries is currently in progress. So general interview structure, it does vary between the deaneries. Typically there's 2 to 3 stations lasting 10, 15 or 20 minutes each. The interviews can be in person, but ever since COVID they've sort of shifted to online because I think they've realised it's easier for the participants and for the examiners themselves. Looking specifically at the Northwest, and I should just give a disclosure as well, obviously I've been fortunate enough to get an SFP place at the Northwest, but that doesn't mean that everything that I say you should trust. Obviously it's just my own opinions from my own personal experience, so take from that what you will. So for the Northwest, it says each interview is going to be 30 minutes in length and we'll have 3 separate sections. So you've got a clinical scenario, a journal review and career aspirations. And the Northwest have changed it in recent years. When I interviewed 2 years ago, there was only the clinical scenario and the career aspirations station, whereas for London they had all 3 of these stations. So it seems that Manchester have changed their criteria in recent times. So what we'll do is we'll just go through each one of those stations. I'll give you some advice and we'll recap some knowledge that you might need for each of those stations. So looking at the clinical scenario, usually you will be presented with a small paragraph about a patient. Usually you're the F1 on call and you've been bleeped, or you're the F1 working in A&E or GP and you've seen an acutely unwell patient. These patients, whilst they are acutely unwell, they're usually not unnecessarily complex. They are all the scenarios that you'll find in the back of the Oxford Clinical Handbook, you know, that emergency and acute scenario section at the back. If you don't have a copy of that book or you haven't managed to find a free copy of the ebook online, would highly recommend literally just learning all of those emergency scenarios and then pairing their advice for investigations and management with sort of current NICE guidelines, because sometimes, particularly you know, Oxford Clinical Handbooks from a couple of years ago might be slightly outdated with the actual treatment advice, but the process that they follow when investigating is definitely useful. I would also advise using the Geeky Medics OSCE stations. Unfortunately, that is a paid subscription, but if there's a group of you applying for the SFP, and if you haven't already taken your finals as well, it's a really useful subscription to have, because they give you an acute scenario and then they label out in A to E what the findings are and what you can say as the examiner. So that's really useful to practice with other people and then to familiarise yourself with the A to E as well. I really liked the clinical scenario station personally, because if you've already done finals, you should know your A to E like the back of your hand. If you haven't, it's a really good preparation for your finals, and it's genuinely really good preparation as well for clinical practice. It's not unusual to come across the sort of scenarios that you're given in these interview stations in real practice. So I think it is good to have to learn and have to prepare. So in terms of your A to E, so what I would say, sorry, you get that paragraph and you might be given 5 minutes to prepare. What I would do is I would just write down, you know, the key details. What are the observations? What's not quite normal? What's your potential differential diagnoses at this point? What are the things that you think you're going to forget to mention? You should be allowed to have a pen and paper. At least I was allowed to have a pen and paper so that you can make notes during that preparation time. So you've written down all of your notes and your preparation, and then I would just go about learning a really good, really slick A to E. So before you've even got to the patient, the examiner will say, okay, so what's your approach to the patient, for example? And you would say, okay, I'm going to introduce myself, confirm the patient ID, I'm going to wash my hands and don PPE. And then I'd get an S-bar handover from the person who called me, who bleeped me, or, if this is a patient attending from GP or A&E, I'd like to try and take a brief history. And the history that you'd say you're going to take is an AMPLE history. So that's the acronym. So AMPLE stands for allergies, medication, past medical history, when they last ate, and events surrounding the injury. So this is based on pre-hospital medicine, but it covers all of the things that you would need to know if someone is acutely unwell. Obviously, you would want to take a more thorough history, but if their blood pressure is crashing, their temp is spiking, what you care more about is the findings in the A2E assessment. Something that you might want to consider doing as well is 2222 calls. So these are for cardiac arrest, or you may have a MET team, the general emergency team that runs in the hospital that helps with acute and life-threatening situations. If you get to the patient and they're not breathing, the first thing you would do, as in doctors ABC, so you can danger, response. If they're not responding, send for help. You probably want to call for the cardiac arrest team, which is usually by 2222 through the hospital phone system. Generally, each stage of the A2E, you want to examine the patient, then you investigate, and then you provide treatments. And then you kind of leave that stage as it is and move on to the next and reassess the effects of your previous treatments after you've got all the way through from A to E. And that's going to be your process. So before you see the patient, you've introduced yourself, you've got an S-bar handover, you've asked for a brief, AMPLE history, you've assessed whether you need to be calling in for some more senior support before you've even done your A2E, and then you're going to start your A2E. Okay, so there's a little c before the A2E. So the little c is more applicable in trauma and in pre-hospital scenarios. And the little c stands for C-spine tenderness and catastrophic hemorrhage. I think it's highly unlikely that you're going to be given a true trauma scenario, but you may be given a scenario where an elderly person who is an inpatient has taken a fall on the ward and you need to come and assess them. So what you'd want to do is just a quick line about checking for C-spine tenderness and looking for any signs of catastrophic hemorrhage before you start. If there is C-spine tenderness, you just palpate down the midline at the top of the spine. If there is any tenderness there on palpation, you'd start to talk about getting senior support. You'd want to do things like log rolling, put their head in blocks, basically keep them immobilized. And then you'd consider imaging, which would be an X-ray or a CT of the neck. If there's any sign of hemorrhage anywhere, you'd want to apply pressure. Consider activating the major hemorrhage protocol if depending on the volume of blood, and make sure you ask for a group and save among all of the other things that you're going to do in your A2E, in case you need to transfuse them later down the line. And again, you consider imaging. So if there is any C-spine tenderness or there's catastrophic hemorrhage, I would suggest at that point you say that you'd ask for urgent senior help. Even as an F2, I'm not expected to manage either of these things by myself. So you interviewing as a medical student, but pretending you're an F1, definitely wouldn't be expected to manage either of these by yourself. Okay, so A, an airway. So what the approach to each step of A to E is: look, listen, feel. That's the examination part. Then your investigations, and then your interventions. So what might you be looking for when you're looking at a patient's airway? anaphylaxis signs. Yeah, brilliant. So that would be angioedema. Yeah, obstruction, perfect. Cyanosis is another thing I've got, and any kind of trauma. So yeah, have they vomited? Is there vomit on the outside of their mouths? Is there any swelling of the lips or the tongues? Angioedema suggesting anaphylaxis. Good. These are obviously things that you would do on instinct. You'd obviously see if a patient's got bright blue lips. Yeah, looking for any visible obstruction like a foreign body in children. Perfect. You do it automatically, but because this is a fake patient and it's an interview, you've just got to remember to say all of these things out loud. So you're looking for cyanosis, trauma, angioedema, and obstruction. And what are we listening for? What might be able to hear? Remember, this is airway and not breathing. Stridor, yeah, great. So, and that would be your audio cue for any kind of upper airway obstruction. And you can feel, so if there's an apparent obstruction that's at the edge of the mouth, if you can fully visualize that, you might want to feel and scrape it out. You might want to use some suction to remove that obstruction. If you can't fully visualize the object, you don't know exactly what it is, and you don't think you're going to be able to use suction to get it out, don't ever put fingers into patients' mouths. First and foremost, use like forceps or something else. But don't use something that you can't fully see, because if you push it back, they're then going to be at risk of aspiration. So if there is any obstruction or angioedema, you might want to consider utilizing an airway adjunct. So those would be your nasopharyngeal airways, your oropharyngeal airways. And if there is any problem with the airway, obviously we call our experts, and you'd be putting out a fast bleep to anesthetics if there's any problem with the airways. Highly unlikely that you're going to get a scenario that involves problems at A, unless it's anaphylaxis, or there's some signs of cyanosis. You shouldn't have a problem. You shouldn't have a problem in A to such an extent that you're going to have to start putting in airway adjuncts, because that leads you more into your cardiac arrest and ALS algorithm rather than demonstrating that you can do an A to E. Obviously, if there's any problems with A and you're calling anesthetics, also call a senior friend. And it's a good idea to know what your role is in the scenario. So if you're the F1 on call, and you've got a problem, who would be, what sort of senior input would you be asking for? Let's forget about the anesthetics team, but say, it's easy to throw out, oh, I'd ask for senior input. Who are you actually asking? Who are you going to bleep to come and help you? Yeah, your registrar or your SHO. I would say if it's an acutely unwell patient, call the reg. So bleep the med reg. If it's a surgical patient, call the surgical reg. And if you're in A&E, you could ask an SHO, a reg, a consultant. If you're at GP, ask one of the other GPs. Yeah, it's good to show that you understand the structure of the hospital environment that you're going to be working in. Okay, so we've dealt with A. There's been no problems from A, but we've said everything that we're listening and feeling. And then we move on to breathing. So what are we looking for in breathing? Oh, gave that away to you, sorry. So yeah, signs of increased work of breathing, perfect. Looking for cyanosis, so any blue around the lips or any blue at the fingertips. Work of breathing, so kind of subcostal, intercostal recession, tracheal tug, use of the abdominal muscles, and chest expansion. Does it look equal? Does it look like they're doing a good breath in? If you're thinking of a COPD patient, are they tripoding? Are they purse lift breathing? Things like that. Okay. And then what you're listening for at breathing. Wheeze. Yeah, good. Crepitations, perfect. Yeah, stridor again, perfect. So yeah, we're literally just going to auscultate the chest, aren't we? And we're listening for any, so we're listening for the normal breath sounds. Is there equal air entry? Is there any added breath sounds like wheeze or crepitations? And you could mention doing percussion. I think in reality, in a busy bay, in a ward or in A&E, it's actually going to be, you're not going to yield a lot from doing percussion that you wouldn't yield from putting your stethoscope on a chest, but it's a good thing to say. Okay, and you're feeling for chest expansion and chest wall tenderness. So checking that that chest expansion is equal, checking that there's no chest wall tenderness suggestive of a rib fracture, and that you can't see any sort of flail segment. So in terms of investigations at this point, let's say we've heard some crepitations, left basal creps. What kind of investigations are we going to ask about at this point? Chest x-ray, good. O2 sats and an ABG, perfect. Sputum, oh, I haven't even put that, but that's fantastic. Yeah, great. Bloods, okay, we'll come back to bloods. You could ask for bloods at this point, but I like to keep things in a very sort of simple order, and we're going to come to bloods in C because C is all to do with blood, so it makes more sense in my head. You can obviously do the A to E realistically in any order that you want to, in terms of the investigations. A to E is structured in such a way that you're dealing with the most important life-threatening things at the start, so the A and B, and then you come to the less important life-threatening things as you get further down the A to E. But the actual investigations you could mention at any point. For me, it just makes more sense to do them in C, bloods. Okay, so I've said O2 sats and respirates. You may be given the obs of the patient in sort of your intro paragraph, but if you haven't, make sure you ask for them because they are obviously essential to assessing how unwell the patient is. And then anyone who presents with any kind of breathing problems, realistically, you're going to be doing an ABG and a chest x-ray, or you'd at least consider it. And then Thomas has said as well, a sputum sample if they've got creps, which I think is a great idea. Okay, and then interventions that you could consider at this point would be oxygen if their sats are low, nebs if you hear a wheeze on their chest, oh sorry, and nebs if you hear a wheeze on their chest. So that also goes for anaphylaxis. Anaphylaxis can present with the angioedema and stridor, but you could also get a wheeze in the chest. So even if you're thinking this is all coming together to make an anaphylactic picture rather than an asthmatic picture, still give nebs if you hear a wheeze. Okay. So then C for circulation. So what are we going to look at for C? Cap refill, yeah, great. So we'll look at peripheral and central cap refill. Okay. So just all of the things that we subconsciously notice about people and patients as to how well they look, their colour, do they look pale? Do they look mottled? Are they diaphoretic? Are they sweaty and clammy and look just gross? Have they got any wounds anywhere that's oozing blood? I think I've put cap refill and feel, but you're absolutely right, Thomas. And so in terms of listening, we're going to listen to the heart sound, and then we're going to feel for the cap refill peripherally and centrally. Okay. What investigations would be like at C? Bloods, yeah. ECG, great. And whilst we're taking bloods, what could we also put in? Yeah, cannula, ABG, great. Yeah, so your line that you're gonna get sick of yourself saying is, I would insert 2 wide bore cannulae into each, like 1 into each antecubital fossa. That's the sort of gold standard, inserting 2 wide bore cannulae, because you'll need 1 potentially for a transfusion and 1 for other good stuff to go back in as well. So yeah, investigations, blood pressure and heart rate, if you've not already been told it, and then IV access, taking bloods, and performing an ECG. So ECG, if they've got chest pain, if they're tachycardic, if they're bradycardic, if they've got an irregular heart rate or dodgy heart sounds, it would all be applicable then. If they're short of breath, you don't know that even if they've got normal heart sounds and they're not tachycardic, you don't know that it's not coming from a cardiac cause. And with your bloods, don't just say, oh, I'm going to take a routine set of bloods list. What exactly do you want? You want, for every patient pretty much, you want an FBC, looking for anemia and infection. You want USANEs to look for baseline for scans and to assess for any dehydration and AKI. LFTs so that we know for future medications, or if they're coming in with abdominal pain, to check for an abdominal cause. CRP to check for infection. And then cultures if they're spiking in temperature or they look a bit septic, and other bloods as applicable to their presentation. And then in terms of interventions at this point, this would be where I'd talk about fluids. So if they've got a low blood pressure, you'd respond to that with fluids. D in disability. So this I've kind of structured a little bit differently because you can put different parts in either D, E, or elsewhere. So you want to make sure that you're asking about a temperature if you don't already know it. You're asking for the patient's GCS or AVPU. I would recommend trying to learn GCS if you can. It's a bit complicated to get your head around, but it would be an impressive thing if they were to ask you at interview. I don't think they're going to ask you realistically, but it might be a useful opportunity to show off. What GCS would you consider getting anaesthetic support and looking, being concerned about an unsafe airway? Yeah, GCS less than 8, perfect. So any GCS less than 8, remember it's 3 to 15. Any GCS less than 8, we'd be looking at airway adjuncts because we'd be concerned they couldn't protect their own airway. You'd want to do a BM to check for glucose, but you could also get a glucose and a lactate, which is useful on a VBG. So just remember that when you're taking bloods. And then in terms of interventions, if they've got a low BM, give them some sugar. If they've got a high temperature, give them some antibiotics. Essentially, at each stage, you're just checking for abnormalities. And if there's no abnormalities, you don't need to respond. You just move on to the next stage. If there's any abnormalities that you think you can do something immediate about, ask for the investigations and interventions, apply those, and then move on to the next step. Okay. And just be aware of your sepsis 6. You're probably bored of this, but can anyone tell me some elements of the sepsis 6? Take 3, give 3. Okay, so what are we taking? Yeah, so we're taking lactate. Yeah, okay, great. Perfect. Great. You know it all off by heart. Well done, guys. So just bear that in mind, because in a panicky interview situation, it can be really easy just to forget one of those things, like monitoring urine output. If someone's got what is obviously cellulitis, probably doesn't seem that important, but it's brownie points if you say all of the elements of the sepsis 6. Okay, and then everything else. So we want to look for wounds, particularly this is more pertinent for trauma cases. You want to make sure you're looking in the axilla and in the groins, because often there can be hidden stab wounds there that can leak quite a lot without anyone realizing, because we don't usually look at people's armpits. Also make sure you're having a look at people's calves and their ankles. So calves can give you signs of DVT, and ankles can tell us sort of heart failure and any peripheral edema. Want to feel the abdomen, feeling for tenderness, feel the calves, check if there's any tenderness there, and Sorry, I'm not sure what that was supposed to say, but is there any other obvious injuries? Oh, feel over any obvious injuries. Yeah. So you just want to feel, for example, if someone's taken a bash on the head, feel over that bump. Is it a boggy swelling? Is it overlying a fracture? Or does it feel sort of firm and bruised? Okay. So that was a real whistle-stop tour of your A to E for the clinical scenario. So my tips for it would be just remember that first bit that I said, obviously that all of the good points are going to come from the A to E, but in reality, you're not just going to pitch up, not introduce yourself, not check that you've got the right patient, not wash your hands. So make sure you're saying all of those things and taking that ample history and the S-bar handover before you get cracking. Just revise the steps of the ATE as much as your clinical scenarios. If you know the steps, that's what's going to get you the points. You just need to ask the questions that to the examiner, are the chest sounds equal? Are there any added breath sounds? And that will allow them to tell you the abnormalities. It's almost like the treatment of the abnormalities isn't necessarily as important, because I'm sure you'll all be safe. You all know with a low blood pressure, give some fluids, high temperature, give some antibiotics. It's not going to be a really complicated scenario. Remember to ask for early senior help. So as soon as you administer any drugs or fluids, just to consider, should I be asking a grown-up to come and help me? Should I be asking for anaesthetics? Should I be getting my reg? Is this someone I would be worried about if I had to deal with on the ward? And just make sure you know why you're doing each investigation. As I was talking through the bloods, don't just say I'm going to do routine bloods. Show that you are doing every investigation with an intention. In my finals, not in one of my not in my interviews, in my finals, I was given the scenario of an Addisonian crisis. And all I knew was you had to give steroids. I didn't really know anything other than that. But I still managed to pass because as long as you're safe with what you do, you say, I'm going to give steroids. Okay, what's the dose? Doesn't matter if you don't know it, because in reality, you don't know the dose of every drug off the top of your head. You would consult the BNF, you'd look at the trust guidelines, you'd ask a senior for help. And all of those are perfectly acceptable answers. I would say, even if you think you know the treatment for something, I would qualify it with, but I would check at the trust guidelines if there's any further interventions or investigations, when you're coming towards the end of the scenario, just to show that you know that each trust and each deanery has different ways of dealing with, say, hyperkalemia. So the OBS will often come with the intro paragraph in your preparation time for the case. So I would write down the essential information, are they hypotensive, pyrexic, whatever. You don't need to put the exact OBS down, but I would just make a note of those key points so that you're constantly remembering it, even as you're rattling through the A to E. And as I said before, write down things that you don't want to forget to mention. So, okay, I've noticed they're hypotensive. I need to mention at some point to give fluids. Okay, so the next station that I'm going to talk through is the journal review. This is personally not something I felt particularly comfortable with. I studied at the University of Manchester and we didn't do a great deal of stats. I didn't feel particularly comfortable reviewing a journal article, so I did a lot of reading around the topic beforehand. This is a really big topic to fully understand stats and how to thoroughly analyze a paper. So I will qualify the next few slides with, I've made a cheat sheet. It's a really boring document that goes through everything I learned before the interview. There's quite a lot of stuff on it, and I'm going to send it out when these slides get sent out so that you can have a copy of it too, because I think it won't do it justice for me to give you sort of a superficial overview of absolutely everything. So I thought I'd go in depth with the most salient points and give you sort of a cheat sheet to go away and look at. And on that note, if you guys do have any questions, I would just say read through the cheat sheet after this session. If you don't understand, come back to Thursday 15 and I will get your message and I can answer. Okay. I would say, as with all of these things, it's memorizing a structure and just working through it and getting really slick with the structure. So when we summarize an article, you might have heard of PICO, but I was told to make it peacock. So PICO is talking about the population, the intervention, the control, the outcome, and the key findings. So if you were asked to summarize an article, you'd probably be given the abstract, and looking at the abstract, you want to see, okay, who are the researchers looking at? Are they looking at 100 65-year-olds at a GP practice in Blackpool? Are they looking at 40,000 pediatric patients across A&Es in America? So that's where you're summarizing sort of the population bit. Then the intervention is, what are they actually testing? So it might be 1 gram of paracetamol post-operatively, or stopping smoking regimes, or things like that. And then the control, is that intervention being compared to a placebo? Is it being compared to another drug? Is it not being compared to anything? Or is it being compared to the current gold standard? And then what were the researchers trying to find in terms of outcomes? So primary, what was their primary outcome? Using statins decreased stroke risk. So stroke risk would be the primary outcome. And then the secondary outcome might be blood pressure or heart rate or something else that they were also measuring, that they happened to measure alongside, but that wasn't the primary focus of their study. And then at the end, the key findings, and so what they found. So an example might be, this study looked at a population of 165-year-olds at a GP practice in Blackpool, and they were examining a daily exercise course, and they were comparing that to doing patients who did no exercise, to find out whether the blood pressure was reduced. The key findings were that this exercise program did reduce these patients' blood pressures, and this study adds to the existing body of literature because it's a randomized controlled trial. It sits high up in the hierarchy of evidence, and we know that hypertension is very, very common in the over 65s. So that would be your sort of summary, and you can do that all from the abstract. It's got all of the key information in the abstract. Oh, sorry, yeah, I should have said at the start, yeah, you absolutely got access to the recording for this session. There's a feedback form at the end of these slides with a QR code. If you fill in the feedback form and put your email, the recording, the slides, and that cheat sheet will be sent out to you. Okay. So I think you'll only get given the abstract in the prep time for this station, and you can find all of these things from the abstract, because essentially it's the bare bones of the study. It's the meat that we really care about. And when you're talking about analysing a whole article, there's a lot more to go into. So initially you want to start with, what question is the researchers asking? What's their hypothesis, and why do we care? Because if the question being asked is not really relevant, in terms of there's not that many patients who have this disease, the disease doesn't impact quality of life that much, why are we doing the research in the first place? Why do we care? So it's important just to draw out, for the example that I gave, the researchers are asking if there's a link between exercise in the over 65s and the reduction of hypertension. And this is important because we know lots of people over 65 have hypertension, and probably that costs quite a lot for the NHS to deal with, and can lead to other comorbidities such as stroke and MI. You don't necessarily need a load of clinical knowledge. A lot of that, again, will still be in the abstract. So then that's when you do the peacock. And just a word here about how to decide which approach you're going for, whether you're just going for peacock or whether you're doing a thorough analysis of the whole article. you should be told at the start of the station, okay, you've now got 10 minutes, over the course of which I'm going to ask you 5 questions, or over the course of which I'm going to ask you 2 questions. And then you can budget your time in your mind of how many minutes you've got per question. So if they said, well, you've got 5 minutes, you've got 5 questions in 10 minutes, please can you give me a summary of this article? You just do Peacock, because well, you've only got 2 minutes per question and you don't know what other questions are going to come. So just do a short, quick summary. Whereas if they said, well, you've only got 2 questions over 10 minutes, you've got 5 minutes per question, so you can do a more thorough analysis and dive into these things that I'm talking about now. So we've talked about the question and the relevance, then we've gone through Peacock, so patient intervention, control, outcome and key findings. Then some prompts to make you think about internal validity. So basically, how well or not have they reduced bias within their trial? So the recruitment of patients, is it multi-center? Is it a single center? How have they allocated the intervention? Has it been randomized? And how has it been randomized? If it has been randomized, have they just got a random number generator and gone, okay, your treatment A, your treatment B, your A? Or have they allocated it in clusters? So hospital A receives treatment A, hospital B receives treatment A, hospital C receives treatment B. And that sort of allocation is done where it would be basically practically impossible to randomize within centers themselves. They just randomize whole centers rather than individual patients. So the maintenance. So this is talking about how many patients that started the trial, finished the trial, completed the full intervention. Does anybody know what intention to treat analysis is? Silence. Okay, so intention to treat analysis. Obviously, you might have 100 patients start your trial, but due to various reasons, you might end up with 83 fully finishing your intervention as planned at the start. Intention to treat analysis is where all 100, even those that dropped out, their data still gets analysed as part of the intervention group up to the point where they dropped out, obviously. Whereas per protocol is where it would only be those 83 that fully saw out the whole intervention from start to finish. That's only those get analysed as part of the intervention group. Then there's blinding. So no blinding would be if, say, it's a surgical intervention, the patient and the surgeon both need to know which surgery is being performed. Single blinding is when the patient doesn't know what treatment they're receiving, but the clinician does. Double blinding is when both the patient and the clinician are blind to the intervention. And you can have outcome adjudication, which is when there's a third-party board that analyzes the effect of the intervention, and they don't know the case that they're analyzing. They don't know if that patient received the intervention or not. So they're blinded, the people who are assessing the effect. Then you can look at outcomes. Is it a clinical outcome that's being used, or is it a surrogate outcome? So it would probably be unethical and would take too long to use rate of stroke as an outcome. Oh, sorry, just going back. So intention to treat analysis does. So intention to treat analysis includes everyone, including people who have dropped out. You analyze all of their data up until the point where they've dropped out, because obviously they might have missed the final 2 months of treatment, but you include all of the results within the analysis. Does that make sense? Whereas per protocol, anyone that's dropped out, you just scrap them. You don't analyze any of their data. And so surrogate outcomes, you use, say you're looking at the rate of stroke, it would be unethical to wait for people to just have a stroke. It might take 10, 20, 30 years to wait for people to have strokes and measure. That would be impractical. So you might use blood pressure as a surrogate outcome for stroke, because we know that, you know, higher blood pressure is related to an increased incidence of stroke. So therefore you can go with the logic of, well, if we decrease their blood pressure, we've decreased their stroke rates, and that's a surrogate outcome rather than a clinical outcome. And then the outcome may have a clinical or a statistical significance. So do the stats actually say it's got a statistically significant effect, or does it just appear like it's got an effect? The numbers look good, but the stats are actually saying that's not statistically significant. And then you get to your statistical analysis, which, to be honest, I am going to leave because I detail in that cheat sheet in a lot more depth, and I won't do it a lot of justice trying to talk it through right now. But the key things that you need to learn about are power, risk ratios, odds ratios, hazard ratios, numbers needed to treat, and equally numbers needed to harm, and p-values. Then you look at the external validity. So how applicable are the findings of this study? Can I relate them to the patients I see? And are these findings applicable to patients all across the world? So looking at resources, the resources that are used in this study, would they be available to my patients? Would they be available across the world? Is the population in this study representative of the population we see, or that might be available across the world? So is the inclusion and exclusion criteria too wide or too strict, do you think? Do you think the demographics of the patients are similar to the patients you see, or are they just well patients because they're well enough to be enrolled in a clinical trial, and actually the real patients you see are far more unwell, have comorbidities, and take more medications than these patients do? You also want to look at whether, you know, sort of the dropout rate. Do patients find this intervention acceptable? So will they use it? And is the frequent follow-up that we often see in studies, is that representative to the real world follow-up that they would get, where it's actually quite difficult to get a GP appointment at the moment? And then looking at the control, is it versus a placebo, or is it against the gold standard current treatment? Because whilst your new treatment may do amazingly compared to a placebo, that's great. But how well does the gold standard treatment perform against the placebo? Is this new treatment actually adding anything, or does it perform worse than the current treatment? And then looking at the recruitment, depending on how the study has recruited patients, it might mean that more enthusiastic and health conscious patients are recruiting themselves to this study. Is that representative of most of the patients that we see? Probably not. And then finally, you just want to look at the funding. Is it funded by a university? Is it funded by big pharma? If it is, it doesn't necessarily mean that there is bias there, but it is worth mentioning that, oh, I can see that it's been funded by this pharmaceutical company. I would just want to check what their alliances are, or, oh, I think it's being funded by a university, so I'm less concerned about any biases. And then in terms of the ethics, are there any risks to the patients? Have there been any side effects that have been noted? Were people dropping out because of these side effects? And then you want to end with a conclusion. So you'd say, in conclusion, this is a randomized controlled trial that showed that implementing a daily exercise program for over 65s in a GP in Blackpool resulted in a reduction in blood pressure. And I appreciate that is a lot of information, that really tried to rush through that to give you a big overview. Okay, so Thomas has asked, will we be analysing a whole article or just an abstract and/or an accompanying graph? I honestly don't know, but what I was given was an abstract. Obviously, there's no reason why you might not be given a graph. I think they wouldn't. I would feel hesitant in saying, oh, they're going to give you a whole article, because I really don't think they will. you don't have enough time to prep to read a whole article. It will take you 20 minutes just to read an article, never mind go through it and try and analyze it. But when I'm saying analyzing a whole article, sorry, I should have phrased that a little bit differently. You can do all of this from the abstract, because even if they don't explicitly mention how they did blinding or how they did the allocation, you can say, I'd want to ask about allocation and blinding because that would tell me about the internal validity of the study. And then if they do mention how they've done it, you can then pick it apart or say, oh, that means it's less at risk of bias because they've used double blinding and they've got an outcome adjudication board. So I think it will likely just be, some figures or the abstract that you'll be talking about, probably the abstract, but this is just a more in-depth way. It's basically, if you're given more time to talk, these are the other things you could talk about, is probably what I should have said rather than analysing a whole article. So my tips for critical analysis would be practice on the abstracts. So just look at abstracts, give yourself 10 minutes, get used to this structure and some of the talking points that you want to say. Write down what your answer would be to sort of analysing this article. And then look at the article itself. They will describe their limitations and their strengths, and see if what you're saying matches up with what the authors have said their limitations and strengths were. If you're not a stats person, which I definitely am not, it felt really overwhelming to begin with, but actually learning the points about internal and external validity didn't take that long to learn, and then they're really easy things to say, oh, I'd like to know more about this, or they've said this, so that means their results are more applicable to the real world. And just some easy to mention points if you're at a bit of a loss. Is the intervention being compared to current best practice? If it is, does it add anything to current best practice? If it's not, that can be a recommendation for future studies. Compare it to the current gold standard best practice. Any side effects that the new intervention has had, and what effect has that had on dropout rates? Are there any confounding variables? Are you measuring the effect of this drugs, but they don't mention if patients were taking any other drugs, they don't mention if patients were smoking, all of those things that are easy just to mention that you'd want to find out about in the rest of the paper. And where does this study sit within the hierarchy of evidence, and therefore how applicable are those findings based on that? So another easy thing to say in your conclusion is, well, the study's found that exercise has a positive impact on the blood pressure of over 65s, but I'd want to have a look at systematic reviews and meta-analyses to fully explore this further and ensure I'm looking at a full breadth of high quality evidence. And then you'd want to have a look at the journal and the impact factor, because that will also give you an idea of if it's been peer reviewed, and therefore if the results are more reliable as well. Okay. As I said, guys, I will send you out a PDF covering all of that in far more detail, and then going in a bit of a deeper dive into the stats as well. I'm not 100% sure exactly what you need to know for the critical analysis section, because it's more of a look of the draw thing. As I said, I was given an abstract, but you might be given a graph. You just don't know what they're going to ask you, unfortunately. So the document I've done is quite long, but it covers the more statty side and how to go through a paper as well. So moving on to the final station then, the portfolio station. So these are things that you probably just want to have good examples for, things that you're ready to talk about. And if possible, I would try not to reuse the same example too many times, because if you give, it's an example that's good for leadership and it's good for teamwork and it's good for conflict resolution, great that you can talk about all of those skills in one thing. But if they ask you for an example of teamwork and then ask you for an example of leadership, you want to be prepared, like you've got more ammo ready to give them. So in each of your questions as well, you do want to try and show elements of the other qualities that I've put here as well. So if you're asked for, a part of research that you've been part of, you obviously want to be able to say, you know, I worked in a team and I took the lead on this part of it, and I struggled with this bit, but I reflected on it, and the way I overcame it was to do this, and I was really proud of it, because, you know, it shows lots of different elements, even if you're not being directly asked about it. So make sure you've got examples of research, leadership, education. Even if you're only applying to the research track, make sure you've got some stuff in your tank to talk about leadership and education as well. I don't know whether the interview board know which track you're applying to. So talking extensively about your research experience, even if you're applying for an education SFP, I don't think they'll mark you down, because they're just marking you on how you answer that specific question rather than the applicability to the track you're on. Also think of good examples of teamwork, conflict resolution, you know, overcoming a big challenge, and then your biggest work or personal achievement. So reflection is key. It's all well and good saying you've got 35 first authored, peer-reviewed journal articles, but if you haven't learned anything from it and you can't talk about what you've learned from it, it won't be as valuable a thing to talk about at interview. Remember the time limits for the stations. So the portfolio station to me felt quite stilted, because I think there were only sort of 4 questions over the course of 10 minutes. And when you're talking for 2 to 3 minutes at a time, it feels quite long, and you kind of lose the thread that you're on, because you're trying to talk about all of these great qualities that you've got, and then you forget what the initial question was that you're being asked. So take your time, think about your answer, pause, and then if you know you've got sort of 2 or 3 minutes to answer, take that time. You know, obviously it's better to sort of undercut it, so do a shorter answer, and then you can always come back to it rather than missing out on a question. But do try and use that time to its absolute maximum. The examiners will stop you if they think you're running over, so I wouldn't be afraid of that. Make sure you know what the SFP that you're applying to looks like. So for the Northwest, for the SFP in education that I'm doing, I get a fully funded postgraduate certificate in medical education, and it's a 4-month block of dedicated teaching and research time. Make sure you know the attributes of the track that you're applying to in that deanery, and link that in with some of the answers. So if they ask you about you know, some research experience that you've had, you could say, well, I did this piece of research, I learned this, I did teamwork through this, I did leadership through this. And that's going to really help me going forwards, actually, because when I've got my 4-month block in the SFP for Northwest, I'd like to continue that research. And then that kind of shows that you know exactly what you're applying to, you know what you're getting yourself into. Think about a project idea that you might want to pursue. You may have no clue what you want to do during your SFP block. You might just be looking forward to 4 months without having to be on the ward, which is totally fine. Even if you don't know what project you want to do, make one up. Think of something. Do a little bit of reading around the subject so you sound like you know what you're talking about, because they want to see people who are genuinely interested and want to pursue, you know, have specific goals. Make sure you know what academic medical career looks like. So what an academic clinical fellow is, when would be the sort of perfect time in a career to apply for a PhD, what's a clinical lecturer. There's a really good flowchart, I think it's on one of the NHS websites. If you type in, you know, SFP, academic clinical fellow, NHS, you should be able to find there's like an academic timeline where it shows at which stage of your medical career you could either take time out or do some academia alongside medicine. And I think showing, for example, in the previous example I said, and I'd like to continue to pursue that project in the 4 months that I get for my SFP, you could then make that answer even better by saying, which would be an amazing sort of first step onto this ladder of academic medicine, because in the future I'd like to pursue a PhD. It shows that the purpose for you applying to this SFP is not only to further your own project and your own research interest, but to enable you get into the career that you want to. You've fully thought about what you're engaging with. I would also say, particularly for teamwork, leadership, conflict resolution, think of examples outside medicine to try and show your breadth. If you play sport or you're in a band or you volunteer, just think of something that's non-medically related to try and weave in if you get the opportunity. If you don't get the opportunity in an interview, that's fine. But obviously, they like to see that you are good at time management, you're organised and you're motivated in a variety of fields, because all of those will help you during your SFP. Okay, we've covered a lot, guys. What time is it? It is 8 o'clock. So what I will do, I will just stop sharing for now. Okay, and I'm just going to get the feedback link for you. Just give me 1 second, because then anyone that leaves can fill in the feedback and you'll get access to the cheat sheet. Okay, right, back. So here is the feedback form, just in case anybody needs to leave early. Before we continue, does anybody have any questions about anything I've said at all up to this point? I appreciate it's a lot of information. Nope. Cool. Right, so for the portfolio stations, the one that we're asking about research and leadership experience, to be honest, you can get any, whether it's sort of a med school interview practice book, job interview practice book, or higher speciality interview practice books, all of those will contain generic questions that will be really, really useful. And it's just a case of just refining your answers and practicing them, but making them not sound too rehearsed. And that's something that you can do. It doesn't even have to be sort of your medic friends. You can do that with family and friends that are used to either interviewing people or have gone for job interviews. So I thought I would just include the more medic-y ones, and I thought we'd run through an A to E together and just do a brief analysis of an abstract. Okay, so this is similar to what you would get. You've got 5 minutes to prepare, and you'd have your pen and paper and you'd sit in silence for 5 minutes looking at this paragraph. So you are the F1 on call. You've been bleeped to assess an elderly lady who has been admitted after suffering a stroke. She has a blood pressure of 90/65, a heart rate of 120, a respiration rate of 32, a temperature of 38.2 degrees, and oxygen saturations of 90% on room air. Okay, so I will just let that be on screen for a minute or so whilst you digest that and have a think about what your approach would be if this was your station and interview. sorry, I didn't unmute myself. Okay, so I can't remember the exact wording of the question I got, but it was something very similar to what I got in my A2E scenario. So then the examiners will turn on the camera and they'll say, hello, can you tell me how you would initially assess this patient? So does someone want to start with how what they'd say? Yeah, introduce herself, wash hands, PPE, then primary survey. Perfect. I'm just trying to work out if there's a way that I can let you guys actually speak. That might be slightly easier than typing. I will try and work that out. We're currently on webinar mode. I can let you individually talk, but it's going to go through and allow you all to talk. That might be easiest. Yeah, with early escalation to seniors. Perfect. Why are we escalating early to seniors? What are we worried about here?
I'm worried about features of red flag sepsis, specifically the systolic blood pressure is very low.
Yeah, perfect. Yeah. What else is pointing you, aside from the low blood pressure, towards sepsis?
Additionally, the tachycardia, the tachypnea, and pyrexia, and low oxygen sats.
Perfect. Yeah, that's a really good answer. You're gonna introduce yourself, wash your hands, don PPE, and look for early senior intervention. You also want to confirm the patient ID, get an SBAR handover, and take an ample history. Okay, so does anyone want to start the A2E and tell me what they'd be looking for? Oh, yeah, we've got loads in the chat. Yeah, perfect. So is the airway patent? Is the patient talking? Perfect. Okay, yeah. So the patient's talking, she's kind of gasping for breath, but she is talking, yeah. So then what's next?
Then I would look for any visible signs of cyanosis, any airway trauma or angioedema.
Yeah, perfect. Great. So we're doing the look, listen, feel bit, aren't we? So there's no signs of any of that. There's no stridor. Okay, so and then Jasmine said breathing, so rate and movement. So you want to do the look, listen, feel approach. So you're looking, does she seem tachypneic? So yeah, this lady looks like she's really struggling for breath. She's got an increased rate of breathing. What's next? Yeah, absolutely. May you request a full set of obs straight away? Absolutely. Feel free to do it however you want to do it. For me, it makes sense to put the obs in the bit that they correspond to on the A2E, but absolutely request a full set of obs at the start. That's perfectly acceptable. Yep, so O2 sats, as in put on oxygen, yeah, and auscultate. So we've looked, and then we're going to listen, we're going to auscultate. Okay, so she's got right basal crepitations and reduced air entry at the right base. Otherwise, her chest is clear. And so then what are we going to do?
A chest x-ray?
Yeah, perfect. So good interventions here would be a chest x-ray and an ABG. And as Jasmine said, we're going to stick her on some oxygen. Okay, what next? see. So cap refill and blood pressure. Yeah, okay. So cap refill is 3 to 4 seconds peripherally, 2 to 3 centrally. Her blood pressure is 90/65. She looks a bit dry. And then Jasmine said, can we get heart rate, fluid status, ECG, and cap refills? So heart rate, she's tachycardic. She's got a heart rate of 120. She looks a bit dry in terms of her mucous membranes. ECG just shows sinus tachycardia, and cap refill is a bit delayed, as I said, peripherally, but fine centrally. Heart sounds are normal. And then, yep, you said establish IV access. So we're going to put 2 wide bore cannulae into the antecubital fossa. Anything else at this point? Okay, great. So resuscitation, stat bolus of fluids. So what's that? What would you give as a resuscitation fluid?
Is it 500 mLs of 0.9% sodium chloride over 15 minutes?
Yeah, over less than 15 minutes. Yeah. And you just want to be aware of whether this patient has any history of any heart failure, has any sort of peripheral pedal edema. You would potentially give like a 250 ml bolus instead of a 500 ml bolus at that point. Perfect. And you're also going to take some bloods. What bloods are we going to take? We said about an ABG, but what are we going to take from the cannula? Lactate, brilliant. Yeah, so we're thinking about the sepsis 6 there, so that's brilliant. Troponin. Okay, why are you thinking about troponin? Can you take cultures from a cannula? You absolutely can take cultures from a cannula. You've just got to take them first before anything else. That's all right. Don't worry if you don't know why you've said troponin. So we've said acute heart failure secondary to an MI, question mark. Maybe that's why I'd take a troponin. So yeah, potentially you could think about that. I think as long as you can rationalize and justify any decision you're making, it's not a bad decision. I would say before taking a troponin, consider whether this patient is complaining of any chest pain and consider whether the ECG is abnormal. They would be my 2 things. And at the moment, given that she's got a high temperature, low blood pressure, and she's got some crackles in her chest, they're only on one side, remember, they're not bilateral. If she was in acute heart failure, the crackles might be bilateral. Okay, that's a great point. Someone just messaged me and then deleted the message, but that was great. I won't give spoilers to everyone else. So I would say probably for this patient, maybe not a troponin, but I think as long as you can justify your decision making, there's not an issue with it. So you'd want to do an FBC, and you're going to be looking at the white cells for infection. Use an ease to have a look at her kidney function as a baseline for scans and for medication. LFTs again as a baseline for medication. CRP to look for infection. Cultures, a VBG, which would give you a lactate and a glucose as well. Anything else we need to think about? I think that's probably about it in terms of bloods. Okay, so we've done C, done an ECG, we've taken the bloods, we've put the cannula in, we've given her a stat bolus of fluid. What's next?
It'll be
Yeah.
D for disability.
Yeah, perfect. And so what would you want to do at that point, Thomas?
So I'd want to do an AVPU,
Yeah.
see how responsive they are, calculate a GCS, maybe do a BM, look for pupillary responses.
Perfect. Yeah, brilliant. Okay, great. So she's alert, she's GCS 15, She's got a high temperature. Her pupils are equal and responsive, size 4, and her BM is 7. So, anything else that we're doing? Or should I say what's next rather than anything else? Okay, so just for completeness, you're then going to do the everything else. So you want to feel her tummy, have a look and see whether she's got any ankle edema. Are her calves soft and non-tender? Has she got any wounds or rashes anywhere that you haven't already exposed? And all of that comes back normal. Her tummy is soft, non-tender. She's got no pedal edema. Her calves are not swollen. They're soft, non-tender. She's just, the portable x-rays just come back round, and she's got right basal consolidation on her chest x-ray. Is there anything else you'd like to do at this point? Antibiotics, perfect. Yeah, great. And a nice line to say is I'd look at the local antimicrobial formulary, or I'd look on microguide to see what the trust guidelines are for the antibiotics. So we've taken a lactate, we've given antibiotics, we've given fluids, we've put her on some oxygen. Anything else? Oh, and we've taken cultures. Is there anything else we want to do at this point?
Would you want to catheterize to monitor urine output?
Perfect. You got what I was saying. So we've done 5 out of 6 of the sepsis 6 at this point. So we'd consider, if she's not already catheterized, catheterize her to look for urine output, and probably take a culture at the same time just to check for the source. But it seems pretty obvious that we've got a chest source of infection here. And that's it. That is, the scenarios are usually not super complicated. You just need to remember your steps and remember how you act when abnormalities come up. What do we think has happened here? Somebody's said it a little bit earlier in the chat, but then deleted it. What is this scenario getting at? What's happened to this lady? Aspiration, perfect. So she's had a stroke. She's probably not been swallowing correctly, and now she's got right basal consolidation and a septic looking picture with a high temperature, low blood pressure, reduced saturations, and some consolidation and on her chest x-ray and some right basal creps. So she's probably aspirated and now got an aspiration pneumonia. So great. Any questions off the back of that? No? Good. Okay. So then, oh, that wasn't at all what I meant. We're not doing a practice portfolio station. Sorry, I meant a critical analysis station. So can you see the whole of the abstract? I'm just aware that sometimes my windows come up and cut stuff off from the abstract. What we'll do is, yeah, great. If you got, we'll just go through that peacock thing that I said. So population, intervention, control, outcomes, and key findings. If I just give you guys a couple of minutes and try and do the peacock acronym for yourself, maybe write it down or type it in your phone notes, and then we'll go through it together. Okay, how are we getting on? Do you want a couple more minutes or you're all right? Okay, let's crack on then. Great. So P stands for population. So does anyone want to share what they thought the population was in this trial? Great. Adult trauma patients at risk of significant bleeds. So yeah, so I would also say, so then Jasmine said adult trauma patients with or at risk of bleeding in 274 hospitals. Perfect. So either one is fine. I would probably say 20,211 adult trauma patients with or at risk of significant bleeding across 274 hospitals, just to keep it nice and detailed. And then that also shows you that it's multi-center and it's a large trial, isn't it? Okay, so what's the intervention? Yeah, TXA, perfect. So a loading dose of 1 gram of tranexamic acid over 10 minutes and then an infusion of 1 gram over 8 hours of tranexamic acid is the intervention, and then the control is a placebo. Perfect. And then what was the outcome that was being measured? Yeah, death within 4 weeks of injury. Perfect. Yeah, you could just say generally death, but yeah, specifically death within 4 weeks of injury, and that's described as being from various causes, isn't it? And so what were the key findings? Yeah, all cause death was lower with tranexamic acid, and also the risk of death due to bleeding was significantly reduced as well in the tranexamic acid group. Perfect. So this is what I put when I did this earlier. So I said 20,211 adult trauma patients with or at risk of significantly bleeding in multiple international centres. And the intervention was tranexamic acid with a loading dose of 1 gram over 10 minutes and then an infusion of 1 gram over 8 hours. This was compared against a control of a matching placebo. The primary outcome was death in a hospital within 4 weeks of injury via various categories. And the key findings were that all-cause mortality was significantly reduced in the tranexamic acid group. The risk of death due to bleeding was significantly reduced in the tranexamic acid group also. Okay, so hopefully you've seen, once you sort of know the process, it's actually not that difficult to pick out these key facts, and that comes out as a very nice and concise summary of what is a large and complicated trial. If you were asked to produce a conclusion of it, a conclusion that I have written is this large international multi-center randomized controlled trial demonstrated that in adult trauma patients with or at risk of significant bleeding, tranexamic acid significantly reduced all-cause mortality and risk of death due to bleeding. And then just looking at some of the other components that we looked at. So looking at internal validity, for the recruitment for this, we can see it is a large multi-centre trial. It's across 40 countries and there's over 20,000 patients. This hugely increases the internal validity and reduces bias by having so many patients in so many different centres. In terms of allocation, this was randomised and balanced within a centre, and it was done by block allocation. So within each centre, they've said a block of 8 has been randomised to either control or tranexamic acid. So they've randomised that allocation. Again, that increases internal validity. They've not said anything about dropout rate, although I suspect that's probably not as applicable with this study. In terms of blinding, it's a double-blinded study. We don't know if there's been any outcome adjudication here. That's something that might be mentioned in the full paper. The outcome is a clinical outcome. It is all-cause mortality and is broken down into various different subcategories. And then the statistical analysis, we can see that it has a statistically significant, so I've just realized I've cut that bit off, which is not very helpful with my textbook. It's got a statistically significant finding in this study. So overall, it's quite a good study. It meets a lot of these elements of internal validity that we're looking at, meaning that the findings are more reliable. How do we know if the outcomes are adjudicated? Usually they say there was outcome adjudication, or we had an outcome adjudication board, or an independent clinician looked at the outcomes and was blinded. Yeah, okay. Okay, so we are basically done with the talk. If you guys have any questions about what it's like doing an SFP, any questions about the interviews, please feel free to fire away. Otherwise, I will just leave you with this QR code. As I said, it's useful for feedback from me, and then we know if we run this session again next year what we can improve on and what you prefer to see differently. And if you enter your email address, you'll then also get the stats cheat sheet that I said I'd send through as well. Thanks so much for coming, guys.
Thank you.
No worries, thank you. Okay, so applying to the Northwest SFP, any ideas on potential projects we can pursue if interested in TNO? So what I would say is, why are you interested in TNO? What particularly do you like? Is it the surgeries? Are there manipulation, like the manipulation of dislocations, pulling of fractures, applying casts? Think about something that you're interested in, and try and see if you can think of any particular projects. Is there any research you've already been involved in to do a TNO that you could then potentially say that you might want to further? Yeah, is that okay? So for example, to give you an example from my interview, I'd already done some research looking at clinical reasoning with the use of virtual reality, and I had no intention of necessarily pursuing it, but I essentially just said I would like to continue this during my SFP years if possible, and as Aintree is linked with the University of Medical School, I could link in with University of Liverpool to do this. So for Northwest SFP, depends where you go, but for Aintree, it's a dedicated 4-month block of SFP time. At certain places, is it Bolton? No, Blackburn. I think it's 1 day a week. But I think that's the only place I know of where it's 1 day a week for SFP throughout the 2 years. . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . You're considering MRI. Okay. I looked at MRI. I didn't like the sound of the tracks, to be honest. But yeah, I studied at Manchester, so I'm sure you'll have a great time there. Good luck.